Hi everyone, I'm Elle Flood. I'm a third year medical student trying to make some videos to help you guys out with some of the step 2 material you're learning now and trying not to forget some of the step 1 material you're going to be tested at the end of your clerkship on. So today's topic is diverticula, and I want to show you a colonoscopy here to kind of really clearly establish what it is. So you can see this colonoscopy, courtesy of Medical University of Southern Carolina, basically has the colon wall and all of these little essentially holes or outpouching in it. And so this is from stress on the colonic wall as stool passes through. So just to kind of remember some of the basic colon anatomy, we have the appendix, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and the rectum. So this blue box is outlining the sigmoid colon because that's the most common site for diverticula. And the other thing to add here, just for reference, is that the appendix and the ascending colon are on the patient's right side. The transverse is sort of split between the right and the left, and the descending colon, the sigmoid colon, and the rectum are on the patient's left side. So you're thinking about that right lower quadrant for appendicitis, the left lower quadrant for things like diverticulitis. So when we talk about diverticulosis, which is the uninflamed state of diverticula, basically what happens is that stool becomes very hard because water is essentially drawn back into the body by the time we reach the sigmoid. So this hard stool and the straining to have a bowel movement can exert a force on the sigmoid wall, and you can see these little outpouchings basically form, and those are the diverticula. And these are actually very common in the elderly, so much so that your patient is typically going to routinely have them above the age of 65 years old. And they're oftentimes these incidental findings on colonoscopy, which is the way that we diagnose them. The treatment's pretty straightforward. It's fiber to reduce the strain. A quick note on colonoscopy is that we want to give people over the age of 50 years old colonoscopy as a colorectal screen. However, if the patient has a first-degree relative who has colorectal cancer, we want to start that screen either at 40 years of age or at the age of that first-degree relative's diagnosis minus 10 years. So if the patient has a mother who was diagnosed with colorectal cancer at 48 years old, they would start their screening at 38. Now, when the diverticula become inflamed, this is when we get into diverticulitis. And like I said, this is almost like a left-sided appendicitis in the way that we can think of left lower quadrant pain in these elderly people who have the diverticula, accompanied by fever and leukocytosis. Now, diagnosis, which I'm going to dive into a little bit deeper, is CT scanning. And what that will show you is inflammation of the left side of the colon, typically. And so you might think about wall thickening. The treatment for this is typically to treat an enteric bug that you think is responsible for the infection or inflammation of these pockets. So we want to give an oral drug as opposed to an IV delivery of things like ciprofloxacin, which targets gram-negative enterics, and metronidazole, which targets anaerobes. If the diverticulitis is refractory to different types of antibiotics or becomes complicated, like beginning to fistulate into other surfaces or forming abscesses, then we might later consider a colectomy, but that's down the road a bit from this picture. So, of importance, when we're diagnosing, we do not want to perform a colonoscopy. The reason why is because, like I mentioned, that colon wall is already weak, and if we are going to do a colonoscopy, we'd have to insufflate, i.e. inflate the colon with air, and that can perforate the colon. Now, reason we might have to check for perforation, besides obviously doing the colonoscopy, is if the patient has hemorrhages, because occasionally the hemorrhages can be formed by vasculature around the sigmoid or the left side of the colon. So this would be performed by an x-ray series like a KUB or a chest x-ray to see if there's free air in the peritoneum. Now, going back to some first step 1 material, and also very useful athletic surgery, I think, is to remember how the enterics are perfused. So let's go through the arterial supply. We have 3 branches from the aorta. You can see up here in red, the most proximal of these 3 is the celiac trunk. So remember that this is the 3 kind of epigastric organs. So you have the stomach, the liver, and the spleen. I like to think that this perfuses about to the area of the ligament of Treitz, so that proximal duodenum. Now, where the celiac supply ends, the superior mesenteric artery, or the SMA, which I've drawn here in green, begins. So that will start at the duodenum and go all the way around the right side of the colon, across the transverse colon, to the splenic flexure right here. Now, there's a place called a watershed area where the marginal artery is basically the connection between the SMA and the IMA. And the IMA, or the inferior mesenteric artery, will go from that flexure all the way down to what's known as the superior rectal artery, which basically perfuses the upper 2/3 of the rectum. And we'll go through this in a little bit more detail because it's a really high yield point for step 1, and also useful for surgery, especially when they talk about hemorrhoids. So just going through all of these specific arteries for a reference, on the SMA side, you have a few things. You have the ileocolic, the right colic, the middle colic, and the marginal arteries. Now, when you get over to the left side, so the IMA, we start with the left colic artery, the sigmoid artery, and the superior rectal artery. So basically, as I mentioned before, if we're going to have a diverticular hemorrhage, it's typically going to be due to bleeding through something supplied by the IMA. So just to go a little bit more into detail about the superior rectal artery that I'm talking about. Basically, the important thing is, if we have the rectum, right, there is an interesting thing that happens in development, which is the inside world that's formed by the endoderm has to join up with the outside world, so basically the skin and the neural progenitor tissue, which is the ectoderm. And where they do that is at this thing called the dentate line, or the pectinate line, which I've basically put here a red line to delineate, again, the endoderm from the ectoderm. And this divides the anus essentially from the proximal 2/3 up here, from the lower third, distally. So in the proximal 2/3, you get perfusion from the superior rectal artery, which is, like I said, a branch of the IMA. Now, from the distal part below that line, you get perfusion from the middle and the inferior rectal arteries, which is very importantly not from the IMA, it's from the internal iliac arteries. So big test points there. Try to remember that. Now, key points, just to remind you, we talked about diverticulosis. Says that's the outpouchings of the colonic wall, especially the sigmoid, that's exacerbated by straining on bowel movements. You diagnose it with colonoscopy. Oftentimes it's incidental, since these people are getting colonoscopy screens greater than 50 years old for colorectal cancer. That's every 10 years. You treat it with fiber. Once it becomes inflamed, that's when it's called diverticulitis. And like I said, it's useful to think about this as a left-sided appendicitis because you have that left lower quadrant pain, leukocytosis, fever. You treat these people with PO, Cipro, and Metro after a CT scan confirms. Do not do a colonoscopy for fear of perf. You can do a surgery if this is refractory or complicated. Finally, if you look into diverticular hemorrhage, you have to rule out perforation, so you can do that with a KUB or a chest x-ray. Step 1 material, just remember the celiac trunk is all of those epigastric organs, liver, spleen, and stomach. Then the SMA goes all the way to the splenic flexure. At that marginal artery, we transition over to the IMA, which goes all the way to the pectinate line. And below that is supplied by the internal iliac artery. All right, thanks guys for following, and good luck studying.